In 1800 in Northern Europe, the maternal mortality was 1 in 100, which is the same as now in sub-Saharan Africa. And in 1900, it was 1 in 300, the same as in Southeast Asia. And then this man came along, and in an article in the British Medical Journal in 1900, I think it was the January issue, he recognized that we were not making all possible progress towards the solution of the many problems of prenatal diagnosis and treatment, and he suggested that there may be a way that we have not tried before. His suggestion was that we should introduce prenatal care, because until that time, whatever care existed in obstetrics related to, number one, the extremely wealthy few of the population that could afford to pay for it, and secondly, intrapartum care. And John Ballantyne recognized that many of the problems of pregnancy relating to death and perinatal mortality occurred before the onset of labor. He suggested, therefore, that there should be prenatal care, and secondly, that this should become universal. He recognized quite clearly that there would be difficulties in the way, and that the idea will be regarded as visionary, which is the usual compliment that you receive from people that are against any change. It sounds really exciting. It is really visionary. It means that, yes, it's really good, but it will not happen. And it is highly unrealistic. And as anybody would expect, the enemies of his suggestion were the medical profession, of course. And this approach of introducing prenatal care would not have happened if it wasn't for some women that used to go around throwing bombs, jumping in front of the horse of the king and getting killed, being arrested, going to prison, going on hunger strike, coming out of prison, throwing bombs and going back into prison. These were the suffragettes that were demanding the vote. Unlike the medical profession, the suffragettes recognized that perhaps the vote in itself is meaningless unless it was also accompanied by something that was relevant to them as women. They demanded that the Ballantyne concepts should be introduced. They managed to get the vote in 1928, and that year they voted the Conservatives out, and the Liberal Party won the elections in England. The first thing that the Liberal Party has done was in 1929 to introduce through this document, maternal mortality in childbirth, prenatal care. The prenatal care that we practice today in Spain, the United States, and in Afghanistan has this great obstetrician as its author. His name is Arthur Greenwood. He's a lawyer, quite attractive, and alcoholic, and he was the Minister of Health in England in 1929. Mr. Arthur Greenwood suggested that we should see women in the beginning of the pregnancy every 4 weeks until 28, and then every 2 weeks until 36 weeks, and then every 1 week until delivery. It sounds very familiar. The rationale of Mr. Arthur Greenwood, which was absolutely true for 1929, is that perhaps most of the problems of pregnancy happened at the end. And they were unpredictable. So there wasn't really much of a point in seeing women in the beginning. However, developments in the last 20 years suggest that the time has come to invert the pyramid of care. Indeed, before we started this afternoon, Moshe was suggesting that we should be starting even before the onset of pregnancy. But the problem is that we cannot find these women. And as a result of, for example, in England, the introduction of first trimester combined screening, there is a decision that every single pregnant woman in England should be offered the combined test at 12 weeks. So that is the first time that we can catch them. I believe that most pregnancy complications are predictable at 12 weeks. And if that was true, then we could have a type of care whereby we could identify a small high-risk group for different types of pregnancy complications that could be seen in specialist clinics, and then a large low-risk group that could be spared the idiotic rituals of touching, measuring tape, and toilet roll on the mother's abdomen to listen to the fetal heart and record, always in the notes, 140 regular. By another visit at 22 weeks, and perhaps another at 36, and for the few that would remain pregnant at 41 weeks. I worked it out that if this was true, we could reduce the number of obstetric visits in England by more than 3 million. But the most important thing is that it will be identifying the high-risk group, and perhaps through interventions, like the ones that you have heard now from Roberto, prevent the pregnancy complications that cannot possibly be prevented by looking at women a lot at a point in pregnancy where most important pregnancy complications have already occurred. Do we have any evidence that this pyramid of care could be changed? The first evidence came from the condition that actually stimulated the introduction of a first trimester assessment in pregnancy. I want to bring a very good example about how dogmas sometimes are created. Because this lawyer suggested in 1929 that we should first see women at 16 weeks, when I was fighting in the 1990s in England for the introduction of first trimester combined screening, the Royal College, the Lancet, everybody that was anybody was suggesting, but this is impossible. And I was saying, but why is it impossible? Because they said women will not come before 16 weeks. And I was trying to understand, why is it that women are so brain dead that it takes them 4 months to realize that if you stop bleeding, if you vomit all the time, and your abdomen is getting bigger, and then you feel something moving inside you, you don't really realize, according to the Royal College, that you're pregnant until you're 16 weeks. And now I realize that it was because Mr. Arthur Greenwood said that women in England in 80 years will not come, because he asked them in 1929 to come at 16 weeks. Why should they come at 12 weeks? And of course, when first trimester screening was introduced, everybody came at 12 weeks. That was about the dogmas of timing of certain things. And then we went through a process, really. We had in the 1970s a method of screening called How Old Are You? And in response to that question, if you were over the age of 35, you needed to have an invasive test. The screening test was translated into a performance called 5% invasive testing rate, 30% detection rate. Between 1970 and 2000, because more women went to universities and delayed having babies, the screen positive rate or false positive rate became 20%, and the detection rate became 50%. In the 1990s, the realization that at 12 weeks, the fluid behind the neck, seen as a black space on the scan, is increased in pregnancies with Downs, increased the performance of screening to about 80%, and in the late 1990s, the realization that free beta HCG is increased and PABE is decreased, created the combined test with a detection rate of 90% for an invasive testing rate of 5. More recent developments have been the realization that there are other placental products that are also affected by Down syndrome, like placental growth factor that is reduced. From the ultrasound point of view, in babies with Downs at 12 weeks, in a high proportion, the nasal bone is absent. In this 4-chamber view of the heart, if you look on across the tricuspid valve, instead of seeing this waveform, you see regurgitation. And if you look in the ductus venosus, you have increased impedance to flow there, translated into absence or reversal of flow at the end of diastole. And in babies with Downs, there is increased flow in the hepatic artery. When you include these other biophysical markers into the first trimester combined screening, then you're beginning to have a screening test with a detection rate of about 98% and a simultaneous reduction in the number of invasive tests. So in terms of the rationale of turning the pyramid of care for chromosomal abnormalities, this is already done. And trisomy 21, trisomy 18, trisomy 13, triploidy, and Turner syndrome, all of the major chromosomal abnormalities can be identified at a high proportion with a low false positive rate at 12 weeks. The next question was whether you could do the same with the identification of other major fetal abnormalities. And by accident, if you're doing a nuchal translucency screening program, you need to measure the crown ramp length. But it doesn't take much time to realize that it is difficult to take a crown ramp length here because the brain is very distorted because it is outside the head. Here, there is a clear visualization that there's a big black space on the top of the head, and this is called holoprosencephaly. Here, the guts are outside the abdomen. This is exomphalos, this is gastroschisis. And here, there's a big black space at the lower end of the body where you're about to try to place the calipers for the measurement of the crown ramp length. And here, it is impossible to find the crown ramp length because this baby is completely distorted since half of it is inside the amniotic cavity and the other is in the coelomic cavity. But these alone, abnormalities that you can see even if you are a little bit blind, within a few seconds, constitute about a third of all the major lethal fetal abnormalities, and they can be diagnosed at 12 weeks. The question was whether you could diagnose some of the others. In the 1980s, the method of screening for spina bifida was by maternal serum alpha-fetoprotein, and in some countries it still is at 16 weeks. The effectiveness of this method was to identify about 3/4 of the pregnancies with spina bifida. Ultrasonographers were suggesting that you can easily see the spine, but nobody believed them. And the truth of the matter is that you could not in the vast majority of centers. And that is why that method was accepted. However, by the mid-1980s, it was realized that you don't really need to see the spine to diagnose spina bifida because the shape of the head was a bit strange. It looked like a lemon, and the back of the head, where the cerebellum is, looked odd as well, and that was the banana. And suddenly, in some countries, like in England, by 1987, nobody was doing alpha-fetoprotein screening at 16 weeks. They were looking for lemons and bananas. However, when we moved into the first trimester, the lemons and the bananas were not very clear. The lemons and the bananas are a consequence of this pulling of the brain down as the amniotic fluid leaks from the spina bifida. So the Arnold-Chiari malformation must have been there, but it was not producing lemons and bananas. And then one day, Rabbi Chawi called me to say that perhaps we should be looking at the back of the brain. And we looked at a number of cases and we put a paper together where this is the normal baby in the same mid-sagittal view as for the assessment of the nasal bone and the nuchal translucency. That is the midbrain. That is the brainstem, the fourth ventricle, and the cisterna magna. And in babies with spina bifida, as the brain is pulled down, the brainstem becomes fatter, and the distance between the brainstem and the occipital bone, fourth ventricle, cisterna magna, becomes thinner. And therefore, this ratio was increased. And more recently, people are beginning to describe the opposite, that if you have something like a Dandy-Walker malformation, the back becomes fatter at the expense of the brainstem that becomes thinner. So here we are in the same mid-sagittal view of the head as for the measurement of the nuchal translucency by accident. You can also diagnose spina bifida. Cardiac defects, of course, have always been the major challenge in terms of fetal abnormalities and their detection. The reason for that is that although there have been fantastic lectures for the last 30 years and an innumerable number of courses to train people how to examine the heart, most people, including myself, are incompetent in doing so. And therefore, the alternative to a strategy of everybody becoming brilliant at diagnosing cardiac defects by looking at the baby was to admit our incompetence and say, why don't we define new methods of identifying the high-risk group to send them to those that are really incompetent? We did have a method called, did you have a cardiac defect yourself, or did you deliver a baby with a cardiac defect before? Are you diabetic, and are you very depressed taking lithium, or are you taking antiepileptics? This was the method of screening for referral to the specialists. If they got to the specialists, they always diagnosed the cardiac defects. But unfortunately, 90% of the babies with cardiac defects were coming from women that did not have a heart abnormality themselves, and they were certainly not depressed before they had the baby with a cardiac defect. If, on the other hand, we were to just look at the basic markers for screening for aneuploidies, the higher the nuchal translucency in chromosomally normal babies, the greater is the chance that there would be a heart abnormality. And if on top of that, you look at the ductus venosus flow and the tricuspid flow, and you just look at the heart to see whether there are 4 parts to it. You don't need to know what is the abnormality or the normality, just that it looks like that, more or less, and is not half as much. Then you can diagnose 75% of the major heart abnormalities at that early stage in pregnancy. Therefore, in terms of addressing the question, can you diagnose most important fetal structural abnormalities at 12 weeks? The answer is yes, you can. And we have heard the brilliant lecture from Roberto on the issue of premature birth. A lecture that often starts, unless it's Roberto that gives it properly, with a couple of depressing but repetitively boring statements. The first statement is, oh dear, isn't it really, really sad that 50 to 75% of perinatal deaths are due to premature delivery? And then everybody in the audience starts crying. Statement number 2. In the last 50 years, the medical profession has been completely incompetent, having realized that the most important problem in obstetrics is premature delivery, to have any impact on the reduction of this condition. Actually, then some even more nasty type of people show a third slide in which they say that in some developed countries, like in the United States, we have been successful in trebling the prevalence of the condition which is the leading cause of death in obstetrics. There were 2 problems for that. And Roberto has said what they were. The first one was that we did not have, or we did not think that we have a good way of identifying the high-risk group. And secondly, the drug that was effective was too cheap for anybody to be interested in it. We can measure the cervical length in the 12th week of pregnancy, but we have to pay specific attention in distinguishing between this line and the glandular epithelium around it that constitutes the cervical length from the isthmus. If we measure the cervical length properly, then at 12 weeks of pregnancy, by a series of basic questions like, what is your height? What color are you? How did you get pregnant? Do you smoke? And what happened to you before? And putting each one of these questions into a pocket computer called multiple regression analysis, you can identify, actually, at 12 weeks, 1/3 of those destined to deliver very prematurely. If in addition to this pocket computer and the 5 questions, you measure the cervical length, and then you measure something like the maternal serum alpha-fetoprotein, you may be increasing that detection to more than half. And we have seen the evidence that certainly when you give progesterone starting from the 2nd trimester, you can reduce by about 1/2 the rate of prematurity, and this is our study and this is Roberto's study, and the results were identical, and we did not collude in manipulating our results. And then you have seen also from his meta-analysis how this can reduce perinatal mortality. Now, something that you did not see in Roberto's slides was that in our slide, because we didn't publish those, if the cervical length was less than 10, the effectiveness of progesterone was much less than if it was more than 10. Perhaps the process of premature delivery had already begun and you could not stop it with progesterone. I think, therefore, if you wanted to reduce the rate further, you may have to be going down to giving progesterone starting from 12 weeks, where you almost never have a cervical length that is less than 15 millimeters. The next issue of interest is preeclampsia. Now, David Wright, that thankfully survived 5 operations for his heart in a period of 2 weeks because the doctors did not realize that he had a heparin-induced thrombocytopenia process, suggested a new concept in terms of preeclampsia. He said that if we allowed all women to carry on indefinitely in their pregnancy, sooner or later everybody would get preeclampsia. And he developed this model where he said, on average, women would develop preeclampsia at around the 55th week of their pregnancy. Now, if your risk for preeclampsia is very, very low, it's because you develop it at 55 weeks, and therefore your risk of developing it before 40 weeks is very, very low. And then, if we look at each of the factors in the history, like how old are you, what is your weight and your height, and what color are you, and what happened to you before, or even what happened to your mother, and then how did you get pregnant, and do you suffer from chronic hypertension, type 1 diabetes, and systemic lupus erythematosus, the effect of each one of these factors is to modify the gestational age at which you would get the preeclampsia. So that instead of getting it at 55 weeks, you sort of get it at 36 weeks. So this is a survival type of model, a competing risks model, a competition between getting preeclampsia and needing to be delivered, or actually delivering before you get preeclampsia. If we start with this, and then we look at a series of biophysical and biochemical markers in the 12th week of pregnancy, then you realize that the uterine artery pulsatility index, the mean arterial pressure, the maternal serum PAB and PLGF are deviating from the normal in those that get preeclampsia, and the deviation is greater the earlier the stage in pregnancy that you develop the preeclampsia. And in this continuous model, then you can combine these parameters and you can have an effective first trimester method of identifying the high-risk group. If we take history alone, for a 10% false positive rate, you can identify about half of the women destined to develop preeclampsia requiring delivery before 34 weeks. And then if you take a series of biophysical parameters, Doppler, mean arterial pressure, and combine them with the history, you get up to about 90%. And then if you add PAB and PLGF, you are getting up to about 95%. So you can, in the 12th week of pregnancy, identify more than 90% of the women destined to develop preeclampsia requiring delivery before 34 weeks. And then what can you do about it? Well, if you give aspirin to pregnancies at high risk for preeclampsia, you can reduce the rate of preeclampsia by about 10%. But that is if you give aspirin at a time when the whole process of placentation is already complete. If you take the same randomized studies that address this issue with aspirin, and you look at them again, of course the number of cases is smaller, the number of studies is smaller, but if you look at those randomized studies, and you look at the ones that gave aspirin before 16 weeks, then the decrease in the rate of preeclampsia may be about 50%. Indeed, if you look further at those studies, and you see whether the endpoint that you're addressing is early preeclampsia rather than total preeclampsia, then the reduction may be about 80 to 90%. However, I repeat, the number of studies that will then fulfill this criteria to enter this meta-analysis is quite small, and it is critically important now to conduct major studies starting from 12 weeks and examining whether aspirin will indeed substantially reduce the rate of preeclampsia. Then if you go to the other issue of the small babies in the absence of preeclampsia. Well, there have been enormous discussions in the last 20 to 30 years as to how to best manage a baby that's severely growth restricted at 28 weeks with an estimated weight of 400 grams. And those discussions are of no relevance to the human race at all. Because the issue of discussion is, should we let the babies die before birth, or should we deliver them so that it is not our fault, but the fault of the pediatricians? The issue is, for me, a dead loss. The issue of how to manage severe early onset fetal growth restriction is to prevent them from being severely growth restricted, because it doesn't really matter whether you wait until the Doppler becomes abnormal before they die, or the CTG becomes abnormal, or the whole world becomes abnormal. They will die sooner or later, before or after birth. As far as the late growth restriction is concerned, that challenge is different. The challenge is our inability to identify that high-risk group. We have to have different strategies for this group, early identification of the high-risk group at 12 weeks, and prevention, and in that group is a different strategy for the identification of the late group. That strategy is likely to be the second or the third component of the pyramid further down. In terms of the methodology, they are similar, because the condition that results in severe early onset fetal growth restrictions is identical to that of preeclampsia. The identification can be undertaken at 12 weeks, can identify more than half of them, and see whether interventions such as low dose aspirin can prevent their existence. And then stillbirth, and the strategy of stillbirth, and again, more or less, there are two types of stillbirths. It's exactly the same as the early onset preeclampsia and fetal growth restriction, is the early, to me, unavoidable stillbirths. Well, can avoid stillbirth, may call it neonatal death, and it is that of impaired placentation. The prevention of this condition is early identification of the high-risk group, same concept, perhaps with aspirin, and avoidance of having this problem. For the late group, only about a third of them are small, and many others have many different reasons for their occurrence. The concept that has become apparent to me is that if you turn up for your 12-week assessment in pregnancy, and you ask people those many questions as part of the necessity for the definition of the risk of chromosomal abnormalities, well, you spend an extra couple of seconds to ask another 5 questions. And then, if in addition to measuring the crown rumplet, the nucleus, you're really good looking at some of the other markers of chromosomal abnormalities, you measure the vitreoretinal index, the venous pressure, the cervical length, and you measure HG and TAVE and PLGF and AFP anyway, then the output would be an individualization of risk for transmission 21 and 18 and 15, preeclampsia, growth restriction, and premature delivery, and then those patients can be seen in specific clinics with the aim of the prevention of those complications. I don't know whether I have run out of time, but since I am here with Moshe here, let me address the issue of gestational diabetes. I have always, when I was a medical student, considered it inherently idiotic to be screening for diabetes in the 3rd trimester of pregnancy. And I was always asking my teachers, but why do we screen for this condition in the 3rd trimester of pregnancy? They were telling, stop asking stupid questions, because pregnancy has the diabetogenic effects. And the diabetogenic effects of pregnancy will make the condition appear in the 3rd trimester. I said, why? But do the women that have these diabetogenic pregnancy-related effects not have different features, the ones that do not have the diabetogenic mediated 3rd trimester effects? I said, stop asking questions. The WH criteria are only met at 24 or 28 weeks, and they are not met at 12 weeks. Then I said, but why would you change the WHO criteria? Well, because it's the WHO. We cannot change the WHO. Change them. Is there a relationship, the question is, between your glucose level after 100 glucose dose at 12 weeks with the glucose level at 40 weeks? Would the women that
would have very high glucose in response to a given load at 50 weeks be more or less the same that would have a high glucose level at 12 weeks? And of course the answer is yes. So just change the WHO criteria to new 12-week type of criteria. Can you, however, identify the high-risk group at 12 weeks? Of course you can. Just ask them here 2 questions. You don't even ask me to ask 5. What is your BMI? And the second, how old are you, by the way? And then, well, you can measure things like adiponectin or sex hormone binding globulin. Then you can identify the vast majority of the women that will subsequently develop diabetes, but you will do so at 12 weeks. And why is it important to diagnose diabetes at 12 weeks or predict diabetes at 12 weeks? Because I spent some time in the 80s with photosynthesis, measuring fetal pancreatic development, and it is very clear that the pancreas is developing in the 20 to 24 to 50 weeks of pregnancy, and the identification of the condition beyond that gestation, then hysterically trying to control diabetes after the baby has already developed pancreatic hyperplasia is already, to me, a lost cause. Now, I then get excited with this slide because everybody, after the lecture of the people that cry with a premature delivery, you get somebody else that again makes the audience cry about the problem of the world, nuclear weapons, the ozone layer, and obesity. This is a new disease that is threatening the whole world. I call this an inevitable consequence of poverty and McDonaldization of the society. That's all. Now, the question then is, what is this condition? Whatever the name is, the higher the BMI, the greater is the risk of miscarriage and stillbirth and preeclampsia and gestational diabetes and last gestational age. And I always suggest that a doctor must be absolutely brilliant to go to the cesarean section on this woman on this couch. Now, to me, we can address the issues in the same way as the missionaries address the issues of educating the world a few 100,000 years ago. We can take women that are like this and give them education on how to eat healthy nutrients, organic food, and how to go to a really expensive but worthwhile gym to exercise. Or you say, you know what, we lost the plot anyway. The best thing perhaps thing that you can hope for is accept the reality that we are going to have these problems, it's going to get worse and worse and worse, and perhaps just give them a tablet that makes them feel less hungry, to eat less of the rubbish that they eat anyway. If that was the case, then perhaps we should, on the basis of the BMI alone, at 12 weeks, be undertaking studies of this nature to see whether we can reduce gestational diabetes and macrosomia. Now, I'll finish off by addressing the issue of multiple pregnancy. Because again, the prevalence of that is increasing. We have learned that this is completely different from that type of twin. And in this type of twin, all of the pregnancy complications are substantially increased. Indeed, the biggest difference between this and that is in those pregnancy complications that if you don't go into the new pyramid of care, you will never see them because they will have already miscarried by the Arthur Greenwood type of care. However, now, again, in this condition, if we identify the high-risk group, we can follow them up, and there is an effective intervention for the prevention. So as far as I am concerned, the Arthur Greenwood model of prenatal care was a major advance. It was not a consequence of a progressive medical profession listening to somebody great and then going out to campaign for it. It was a consequence of people against the medical profession, the suffragettes, the women themselves that demanded the vote. They demanded the introduction of prenatal care. Either the medical profession takes this on, or as happened with nuclear fertility in England at all, it was the case, the women will take it and then they will force the profession to take it. But as far as I am concerned, it is abundantly clear that the time has come to invert the pyramid of care, concentrate in the beginning of the pregnancy, and aim to prevent the parents' complications rather than try and catch them and not know what to do with them once they have occurred. Thank you.